Hello, everyone. Bonjour. Buenos dias. Goedendag. My name is Marion Pitters, and I'm delighted to be the facilitator for today's webinar. I'm here to introduce our expert speakers, moderate some questions for you, our audience members, and ensure that the webinars progress according to the schedule so that we respect everyone's time. But first, on behalf of McMaster University, it's my pleasure to welcome you to the first webinar of the 10-part series, Expert Perspectives on Pandemics. We have participants from all over Ontario, Canada, and the globe online today. Graduate students, faculty from McMaster and partner institutions, as well as representatives from the Pan American Health Organization, PAHO, the World Health Organization, WHO, and some select invitees. Many of you are preparing to contribute your skills to mitigation of the COVID-19 pandemic. We welcome you all to today's compelling session. The COVID-19 emergency presents a global challenge to our healthcare systems, our economy, and our ways of living. In the face of this unprecedented global health crisis, McMaster is dedicated to innovation and collaboration in the discovery of solutions to help combat COVID-19. This series is integral to the Master of Science in Global Health. Experts will delve into topics including historical trends, vaccine development, the threat of antibiotic resistance, and Canada's research response to COVID-19. A quick overview of the 10 webinars in our series can be found at the link where you registered, globalhealth.mcmaster.ca 2020 webinar series. Today's session is Webinar 1, Learning from Past Epidemics, from Black Death to COVID-19. It features Dr. Hendrik Poinar's historical perspective on a number of pandemics and implications for COVID-19. Just a final housekeeping note before we start. Time has been built in for questions and discussion at the end of the webinar. Please use the chat tool to submit questions electronically throughout the presentation. And please note that while we may not be able to get to all of your questions, I will be forwarding them to our speakers, and we will aim to address them afterwards on the Global Health website. At this point, I would like to introduce Dr. Paul O'Byrne. Paul is the Dean and Vice President, Faculty of Health Sciences at the Michael G. DeGroote School of Medicine at McMaster University. Dr. O'Byrne is a professor in the Division of Respirology in the Department of Medicine and is world-renowned for his research on asthma and the mechanisms that cause airway inflammation. He's a prolific publisher of almost 400 peer-reviewed papers, has edited 10 books, and is a frequent lecturer at international meetings. Paul, will you please start us off with a few words about launching this webinar series?
Well, thank you, Marion, and thank you, everyone, for joining us for this Global Health webinar series from McMaster University. We have over 400 participants joining us today. It goes without saying that these are very challenging times for everyone across the globe as we adjust to life in the midst of the COVID-19 pandemic. We organized this speaker series to reflect the transdisciplinary nature of global health. Each speaker will focus on their specific area of interest, but in the context of COVID-19. Starting with Dr. Poinar with learning from past pandemics in today's webinar, and moving into contemporary issues in pandemics. This webinar series shares expert reflections from ethics to mathematical modeling, laboratory science, and cultural concerns. I want to particularly thank the speakers for sharing their diverse and expert perspectives on pandemics with you, as well as our faculty and partners in global health who organized this unprecedented learning opportunity for us all. In my view, we have the expertise online today to generate some groundbreaking progress in the discovery of innovative solutions to help this COVID-19 pandemic. Thank you and enjoy the series.
Thanks, Dr. O'Byrne. Before I introduce the first speaker, a quick reminder again to post your questions for our speakers in the chat box. Now on to our first speaker. Dr. Hendrik Poinar is the director of the Ancient DNA Centre. He's an evolutionary geneticist and professor of biological anthropology. Dr. Poinar is interested in the origins, evolution, and dynamics of infectious disease through time. His stellar team uses ancient DNA isolated from victims of past pandemics, i.e. Black Death and the plague of Justinian, to address questions about what caused these pandemics and how they have evolved since. When not thinking about infectious disease, Hendrik plays the drums in a faculty rock and roll cover band called the Null Hypothesis. Dr. Poinar, tell us about what we can learn from past epidemics all the way back to Black Death in the 1300s.
Great. Thank you, Miriam, for the introduction, and I want to thank Dr. Bauman and Dr. O'Byrne for this opportunity to present, and thank you for all of you that are listening in and paying attention. Today I'm going to try, hopefully successfully, to show you some parallels and differences between past pandemics and the current one that we're all living through. I'm going to make particular reference to a pandemic that I've been studying for quite some time, my group and I, and that's, of course, the Black Death. So in 1346, an unknown miasma, or a bad air, was spreading across the Middle East through the Horn of Africa and eventually consuming Europe in about 5 years. And it didn't discriminate. It took the old, it took the young, it took the sick and the healthy. Archaeological evidence that suggests such. And it even took animals that cohabited homes with individuals that were themselves sick. And in most cases, it killed within 24 to 48 hours, but for some, death came quickly in as little as 7 hours. So massive mortality in short amounts of time. Unfortunately, no one really understood where it came from, and importantly, why. It was what we refer to as a shock disease. Cholera is a good example of a shock disease. It comes out of nowhere and all of a sudden consumes a large percentage of the population. And despite its invisible approach, it left, of course, as infectious diseases do, visible traces in the individual bodies that it consumed. This is probably most famously represented by Giovanni Boccaccio's Decameron in Florence, describing the plague in 1348. The symptoms were not the same in the East, where a gush of blood of the nose was the plain sign of inevitable death, but it began both in men and women with certain swellings in the groin or under the armpit. They grew to the size of a small apple or an egg, more or less, and were vulgarly called tumors. In a short space of time, these tumors spread from the 2 parts named all over the body. Soon after, the symptoms changed and black or purple spots appeared on the arms or the thighs or any other parts of the body, sometimes few large ones, sometimes many little ones. The bubo was the inevitable sign of death during the Black Death. So despite the ignorance, if we want to call it, of medieval Europeans, they knew full well that something was wrong, but they had no idea where these infectious agents were coming from. In fact, they weren't infectious at all. They were evil stupors coming from the heavens. And this is portrayed mostly in the iconography and art of the times as, for example, the angel of death. Without proper understanding of the cause, the only true explanation was punishment for our sins. And death here is shown shooting or losing its arrows of pestilence against the sinners. And the sins of gambling and lechery are being punished here, for example. And gamblers and lechers actually were thought to be prime targets for the plague. Of course, it affected everybody. Children, for example, had mass mortality in children, are not gamblers and sinners at the onset, of course. Intercession of saints and other sacred individuals believed to provide protection against the plague. So if you could be protected by a holy saint, for example, maybe you could avoid the arrows that were being flung from the heavens. Saint Roch, here painted by Tiepolo in 1730, was one of 2 very famous saints whose protection was invoked against the plague as he traveled the landscape with his dog. Here he raised his tunic to show a buboes on his inner thigh. Many claimed that they saw ominous portents that presaged the plague, but there was a change in the landscape, earthquakes, weather, fire, and of course war and famine. And these all came before the Black Death actually hit. Once the plague hit, the most common sight for the Black Death were the biers carrying the multiple corpses across the cityscape and opening new pits of burial pits, as the one shown on right, the now famous East Smithfield Plague Pit, which we've held with the excavations in the 80s, that was being built by the King's decree in 1348. This was a farmer's field that was changed immediately to a mass burial pit in England as they tried to cope with the highly rising numbers of plague victims. Here you can see this as an archaeological excavation with the horrors of the epidemic, and bodies in 1348 were being thrown into the new dug trenches. Dirt was sprinkled between the layers of limbs and torsos, and as Anne Carmichael famously described in an article, like lasagna. The ground was then hastily sanctified. So it's not surprising if this was your everyday scenario in 1348, that a common and expected and normal response would be fear. When no one has no recourse, when the agent itself causing the disease is invisible, one defaults to fear. So keep in mind that it wouldn't be another 550 years after the Black Death had ravaged Europe that Alexander Yersin, the Swiss biochemist, would identify the causative agent of plague during the Indochine plague epidemic in the late 1800s. And of course, that causative agent, that etiological agent of plague, or bubonic and septicemic and pneumonic plague, is of course the Bacillus yersinia pestis. And of course, Alexander was standing on the shoulders of true giants in germ theory of disease, and those of course were Robert Koch and Louis Pasteur. Koch, famous for the discovery of the cholera bacteria and formulating the postulates which of course define germ theory, and of course Louis Pasteur showing the existence of microorganisms and demonstrating the utility of germ theory in understanding infection and disease. But I'm getting ahead of myself, of course. In 1346, the plague was a new disease. The second pandemic, which begins with the Black Death in 1345, has its origin somewhere in the east, somewhere in the Crimean Peninsula, in the city of Kaffa. From there, it was soldiers returning from battle that brought the plague to Constantinople on plague ships. From Constantinople to the ports in Messina and Sicily, eventually up into Genoa, onto Marseille, across the lands of Bordeaux, and eventually making their way in 1348 into London. And within 5 years, eventually consuming Europe. By the all-toll end, the Black Death had killed an approximate number of 30 to 50 million people, which represented at the time, of course, here the mortality rate being something on the order of 30 to 40% of the population, which is really an unimaginable number when one tries to understand that, or certainly relative to pandemics that we're living through today. And of course, the Black Death here shown on the x-axis on the far left in bright red was the first of many repeated decadal outbreaks of plague that lasted for almost 500 years. So the Black Death was just the beginning of the second pandemic's long burn. And of course, this wasn't the first time plague had erupted. The Black Death is bookended by the first pandemic, what we refer to as the Plague of Justinian in the 6th to the 8th centuries, and was still referred to as the Great Mortality some 700 years later. The Plague of Justinian brought an end to the reign of Emperor Justinian, here shown in the upper right-hand portion of the slide, and as you know, was a new epidemic at that point in time, which ravaged Europe, also killing something on the order of 20 to 30 million people. In the absence of or vacuum of a cause or an identifiable agent, the common response, apart from fear, is blame, intolerance, and racism begin to raise their ugly heads. During the Black Death, it was common that Jews and prostitutes were often blamed for poisoning the wells or having simply aroused God's anger. And the response to that in many cities was to hire religious flagellants who would beat themselves in the hopes of absorbing the sins of the people that were leading to these diseases. The artwork, which of course immortalizes, which is immortalized in churches and monasteries across Europe, has really come to represent the experience of plague, which is the image of death and dread. When we think about pandemics and plagues today, we draw direct imagery that goes back some 500 or 600 years. These are the images of plague. And although its history has often been cited as a human contagion, we must not forget that plague is a disease of rodents. And humans are simply accidental hosts that zoonotically obtain the infection from rodent epizootics. So rodent infections spill over to commensal rodents, which eventually then through flea models move into humans. So rather than think of epidemics as singular causes, it's better to think of them as Professor Riese put it, the result of a complex interplay of biological and social factors, which at certain points in our history create favorable ecological niches for given diseases to thrive and therefore decimate humankind. So in that vein, that our research group here, working with collaborators from around the globe in multiple fields, think about and try to understand the reemergence of pathogens from how and why do pathogenic strains arise? When and where have they emerged in the past? What were the underlying anthropogenic and environmental influences that enabled this emergence or reemergence? Can we, by sequencing them genetically, map their transmission speed and space through time? Were they more infectious in the past than they are today? Can we track changes specifically in their virulence in real time? And to that end, we spend most of the time, my graduate students, excavating the remains of victims from mass burials that are linked to pandemics. So here are 6 individuals that were hastily buried during the Black Death from East Smithfield, excavated in the late 80s. These are meticulously curated by a collaborator of ours, Dr. Rebecca Redfern, for the Museum of London. And it's actually the teeth that then we carefully take out of these mandibles and maxilla to actually analyze the DNA deeply embedded within the pulp cavities of these teeth, because the pulp cavity contains the blood, which contained the septicemic organisms which were infecting these individuals 500 to 600 years ago. It's quite amazing to imagine that these are still actually preserved deep within these individuals that have been buried for 600 years. And it's in the clean rooms here at McMaster University, in these carefully controlled rooms, that my phenomenal graduate students carefully extract the DNA from these remains, these victims' remains, and try to then identify the pathogens that killed these individuals. But the DNA of pathogens represents a minute fraction of the total DNA that exists in these skeletal remains. So here I've illustrated just a pie chart showing that the bulk of the DNA really has no match with contemporary databases, and that small, tiny percentages of DNA actually match Yersinia pestis. So the burden, the task that we had was how to actually rebuild these ancient genomes to make sense of them in an evolutionary perspective. So the way that we did that was to come up with a method called targeted capture or enrichment. You could think of it as a type of fishing game. So let's take Yersinia pestis, the causative agent of plague, and let's open up its hood. And inside the Yersinia pestis bacteria, you see the genomic architecture which underpins it. There's a large chromosome of about 5 million bases, and there are 3 important plasmids which play a role in its virulence and its transmission and its adaptability to its host. What we do is we take that modern genomic architecture and sequence, we shear it up into little tiny pieces, and we place it onto a microscope slide, as you can see on the bottom of the figure, as a solid phase form of capture. And then what we do is we take the DNA from a tooth, we put it into a tube, and again, this represents a minute fraction of the total DNA as shown here in that pie chart. And we float it across those microscope slides, or we do it in solution on magnetic beads, and we capture the pieces of pathogens pathogenic DNA that hybridize to the similar stretches of DNA from the modern pathogen. Then that means we can artificially increase the relative proportion of ancient pathogen DNA to the background contaminating DNA of the environment, say, for example, so bacteria that have leached in over the burial time. And then, of course, we deeply sequence those on next-generation sequencers, and the bulk of our time then is spent on the other side of excavating the skeleton, which is really bioinformatics and rejigging these genomes from ancient times back into a modern enclosed genome for comparative purposes. And we've gotten pretty good at this. Here are the genomic underpinnings of the strain of Yersinia pestis that infected and killed millions from the plague of Justinian. So on the left-hand side, you can see a reconstructed full chromosome. On the right-hand side, we've reconstructed the plasmids from that ancient genome. And then what we do is we place these into a phylogenetic context. So this is a cartoon that represents a phylogenetic relationship between human and rodent strains of Yersinia pestis. All the strains colored in green at the bottom of this network or tree derived from rodents, as you can see with my little mouse pictures at the bottom there. All the ones that are colored and non-green at the top, these represent strains that have been isolated from humans. So you can see here that the root of the tree at the bottom actually sits buried within rodents. And remember, this is a disease of rodents after all. But where do the ancient genomes sit? Well, it turns out the plague of Justinian is a separate emergence that occurs actually embedded close to the rodent strains. And what's so interesting and important about this is that it represents an emergence, but then an extinction event as well. Because as we can see on this, there are no descendants of the Justinian epidemic circulating in wild rodents or people today. But that's a very different story from that of the Black Death strain, which sits here at the base of an explosion of human strains. In fact, the Black Death pandemic is responsible for seeding the world with its particular strain of Yersinia pestis as the ancestor of nearly all human outbreaks still occurring today. So you can see here I've got the Black Death skull from East Smithfield, and it's sitting at the base of everything I've colored now and highlighted pink. And so it's amazing to think that the Black Death epidemic in 1346 is responsible for seeding all the contemporary human pandemics of plague. So an event that took 600 years to do. Think about that in contrast with the way SARS has moved across the globe. After the repeated emergences of Black Death, which eventually made their way back into China and eventually made its way to Hong Kong, ships that left Hong Kong to the west coast of California in 1902 eventually would seed plague that originated again from the Black Death into wild rodents all along the west coast from Canada to Mexico. So here you can see on the bottom the picture of San Francisco during a plague epidemic. Squirrels on the west coast, which are common carriers of plague now. So what can we study? What can the study of past pandemics like the Black Death teach us about new or re-emerging plagues like COVID-2? The first thing to remember is that much of what we know and feel about epidemics today is anchored in past epidemics. For the Black Death, there are similarities as well as differences that we should actually consider. And it's important to remember that plagues have come to occupy powerful mythic spaces in cultural history, and in turn they've become metaphors for other unforeseen and frightening calamities of human existence. So we used to think of them incorrectly as phenomenon of the distant past or distant places, but we know all too well, as we all sit in our self-isolation today, that that's not true. First and foremost, again, fear, a universal response and more like the art of the time. And I want to apologize here to Edward Munch. This Oreo cookie on the right-hand side is not quite the image that will resonate for years after COVID subsides, but ask yourself, why did this particular quarantined individual decide to etch this image into his Oreo filling? Fear is a natural evolutionary response to the unknown, to infection, and since much of it is anchored on our early inability to know what precisely was causing the infection, it makes sense that it forms part of our response today. By the late 14th and early 15th century, Italians knew full well about the plague and its contagion, so suspected ships with sick individuals were quarantined. That is, they were marooned for 40 days, the word from which quarantine derives, on lazarettos in the Venetian lagoon, here shown on the right, before anyone was allowed to come ashore. That looks surprisingly similar to how we continue to respond today. The key with quarantine is to move quickly. No benefit comes from acting slowly or denying the existence of an infection, does it? During the plague, unknown and known victims were buried in trenches, for no one could or wanted to claim them, with the risk of catching the foul miasma that might have affected the victims themselves. Here on the left-hand side, you can see basically 300 years of victims buried from Italian recurring plagues during the second pandemic. And on the bottom right-hand corner of the slide, in New York, Banks Island has served as the burial grounds for unclaimed victims. And this is being used extensively as the epidemic of COVID-2 ravages New York City. Some would argue that the hazmat suit here shown on the right has origin in 17th century plague doctor apparel. Of course, the plague doctor, aren't we still trying to do the same thing, which is to keep bad air out? And it's important to remember that plagues ultimately speak to relationships between people. The study of plague allows us to ask who gets sick and who doesn't, who cares for whom, who dies and who survives. How do diseases cluster in some groups and not others? Plagues always speak to global inequities, where some places can better fight them, while others can't because of the lack of resources. Think about where the bulk of reporting has stemmed from, and ask yourself, why is that? Diseases cross borders, but sometimes cures often don't. Here I'm thinking about cholera in Haiti after the horrific earthquake on the left-hand side, and on the right-hand side I'm showing responses in Ecuador and Africa to the current epidemic of COVID-2. Plagues inevitably come from somewhere else, and they are someone else's fault. Here, Napoleon, in this depiction, painted before his coronation as emperor, is visiting the defeated Ottoman soldiers in his battle to gain the East, emphasizing the difference here between the Middle Eastern Ottoman soldiers, all infected and dying in this illustration, and the French, who are, of course, exceptional. This described at the time, and still, as many historians have described it, a type of form of European exceptionalism. Of course, the Europeans don't get sick, whereas those from other countries and from its origins in the East, they of course do. This imbalance really emphasizes the misperception that some are better or more blameworthy than others. Of course, look carefully at Napoleon's doctor here, illustrated behind Napoleon. He knows fairly well what's going on. He's going to cover himself with a mask. So the idea that plagues come from somewhere else is rooted in the idea of other as dangerous, or the dangerous stranger motif that we see so common in film and life today, and representation in media. It allows countries to play out nationalist myths about our superiority of the way of life, the unequal quality of our healthcare systems, our modernity compared to their lack thereof. Blame in COVID, of course, as has been said by certain political leaders, as a Chinese virus, for example. And when blaming a particular country comes to an end or doesn't, the locus of blame is turned to the sick themselves, and the negative meanings attached to the disease become applied to sufferers. Sufferers come to embody the disease and the meanings attached to it with stigmatization and blame. Cholera in the 19th century Europe was blamed on the poor. Individuals with syphilis in the 20th century North America were viewed as morally sick and a danger to the social order. The refusal to imagine that plagues can originate on our own soil partly explains why they are often met with denial. The presence of plagues is tacit admission that something is wrong with the system, as Mark Nistor said. It's an embarrassment to states for whom epidemics are seen as failures. And one can expect denial when sanctions against admitting the presence of plague are huge. So look what happened during the 1918 influenza epidemic, when only Spain was freely allowed to report on people dying too. No other Western countries were allowed to report on the epidemic for the fear of demoralizing the war effort. And because of this, that name stuck, and it's been ever known since as the Spanish flu, despite the fact that it doesn't have any of its origins or its true evolutionary history in Spain. Plagues reflect our relationship with nature at a very fundamental level in terms of our relationship with other animals. The concept of one health is therefore vital. Humans are part of a wider web of interactions that involve humans. Land use changes leading up to the Black Death because of an increasing and growing and a hungry population unwittingly created spaces for rodents to feed and breed, and these eventually spilled the plague over into rodents. Plagues are symptoms and expressions of this relationship with nature, and during the plague, the rat became, of course, the scapegoat. So hunting and killing the rat was seen as a viable method of preventing plague. For COVID-19, the bat and the pangolin have resumed that role. During Ebola, it was the gorilla. We need to think carefully about our interaction with the animal world in a way that doesn't harm the fragile ecosystem that already sits on a perilous tipping point. Remember that humans, not animals, after all, are the most important source of infection for each other. Let's think about some of the differences between the past epidemics and the current one we're sitting through today. During the Black Death, again, they had no idea what they were dealing with. These miasmas were unknown nebulous sources of foul air being spread through medieval cities. Today, we have exceptionally well-characterized viruses, coronavirus, SARS-2 in this case, that have been not only genomically characterized, but imaging and even beginnings of the workings of immunology and serology to work on vaccines. One of the true heroes of the current pandemic has been the real-time genomic epidemiology that is tracing virus transmission and evolution in real time, looking, for example, for escape mutations that might play a role in creating false negative testing or as possible escape mutations for vaccines down the road. So the genomic scale is unparalleled with anything before it, even including the Ebola epidemic. The Black Death took 500 years to spread not only across Europe, but the globe. And remember that everything that is seeded today with Yersinia pestis has its origins, its roots in that epidemic 550 years ago. SARS-2 or COVID took 24 hours or maybe up to 2 months, depending on how you time it, because of the speed of connectivity between populations and continents today. It's a very different time period. One thing that we should be very careful to distinguish is also the human scale. Well, they're both pandemics, both COVID and Black Death and Plague of Justinian. One should be careful at comparing these scales of these pandemics. After all, it is human life ultimately that we were talking about. The Plague of Justinian and the Black Death combined took somewhere on the order of 50 to 100 million people, again representing half of the population of the European, Middle Eastern, and North African continents, which is a number that is, again, almost impossible to imagine. And while the number of deaths continues to rise today from COVID, it is important to remember that at the individual level, statistics really have no meaning. And in the place of prayer in 1665 London, when again and still we had no idea what was causing these repeated outbreaks of prayer, in that stead today we have science. Plagues transform society in a host of ways, both large and small. Hendrik Poinar argues that Black Death changed attitudes to children in the 15th century, making them much more precious. TB incidents led to changes in fashion and inspired laws prohibiting behavior. For example, you could not spit, and required institutionalization during the sanatorium movement. And HIV/AIDS gave new meaning to the substances of life, blood, and semen, changed them into potential sources of death. The question you have to ask yourself today and over the course of the next several months, It's how will this pandemic change you, your beliefs, your interactions, your priorities? Because the shape of future plagues will always continue to reflect human biosocial relationships. They'll tell moral tales, and they'll be read for their social, economic, and political meaning. And although we may, in our short-sightedness, egocentrism, ethnocentrism, presentism, Eurocentrism, think that our experience today is unique or special, and in some ways, of course, it is. Examination of past epidemics provides a framework for thinking about the analysis of the perennial problem of plague, because, as Camus remarks in his famous novel, Plague, we are and never will be free of plague. We just need to remain constantly vigilant. Thank you.
Thank you so much, Hendrik. That's a lot for us to think about. Everyone be sure to submit your questions in the chat section. A first question, with a mortality rate of 30 to 50% during the Black Death, humans themselves must have gone through a tremendous bottleneck. Hendrik, is there any evidence to suggest that this has changed our immune system today in any way?
That's a really interesting question, and one that we've actually begun to analyze. It's impossible to imagine that a 50% mortality rate wouldn't lead to a massive bottleneck, which of course would affect by selection our own immune system. And of course, we see that in the analysis that we've been looking at today. So we've analyzed the genetic or genomic underpinnings of victims prior to the plague, during the Black Death, and after the Black Death for several hundred years. And we see a massive selection towards certain variants or alleles of particular genes that are involved in immune function. So if you are a descendant of European ancestry or Middle Eastern ancestry, or even Northern African ancestry, then you are a product of your ancestors who made it through the Black Death and the plague of Justinian, and you have an increased frequency in a particular set of alleles that probably gives you increased susceptibility, increased protection to plague.
Okay. Can you characterize any components of COVID-19 as being a bottleneck?
Right now, that's interesting. So the only bottleneck that we see, of course, is we see that there's a higher mortality rate. And of course, mortality rates are still not completely well established, but we definitely see a bottleneck in elderly individuals. We see a bottleneck occurring in those that are immunocompromised or with underlying conditions, which of course is something we're looking into during the Black Death as well. And of course, we see bottlenecks potentially occurring where healthcare systems are just improperly funded or there's no proper access to healthcare. Those will result in bottlenecks. And so in each of those cases, there will be selection against or for particular alleles.
Okay, thank you. Next question. Were these plagues self-controlled, or were they controlled through specific public health interventions? I'll say that again just so everybody has a chance to think about it. Were these plagues self-controlled, or were they controlled through specific public health interventions?
The only control that we really know about, and this came in the form of quarantines and the isolation of sick into pest houses. So anybody who is either paying and listening in Europe knows that, of course, there are famous pest houses or plague houses littered across Holland, for example. I know there's some even in Utrecht, where I was born. And this is where sick individuals were placed in the hopes that they would then not spread the disease to other people. And then, of course, quarantine in Italy took place in the 14th and 15th century. And in some cases, it was successful. In many cases, it was not successful because most of those ships carrying plague that came in that were attempted to be quarantined had important cargo on them, in a lot of cases perishable cargo, and so eventually people would try to make their way into the cities to still sell the material. So it's very unclear yet how effective quarantine really was. But I think that, you know, one of the most important places, Ragusa and Dubrovnik in Croatia, was really some of the best quarantine and controlling measures that took place during the early periods of the second pandemic.
Okay, okay. More coming in for your expert opinion here, Hendrik. Here's the next one. It seems as though much of the information that we get about society during the Black Death came from paintings. Do you think that social media will play a similar role with COVID-19?
Yeah, that's a really interesting question. A lot of the information that we gather are from written documents, but the bulk come from the art at the time, and that's both good and infuriating for someone that looks at that. So in some cases, it's fantastic because it gives an impression of what life was like and must have been like. But of course, if you're an artist and you're trying to illustrate an epidemic of this proportion at the time, there'll be a tendency to exaggerate. So there's been a real changing of the courses over the recent years, that a lot of the illustrations representing, for example, plagues, which will have littered poxes across the face, are probably not exactly what we think they are. They may not be plague per se. They may be smallpox. They may be other forms of typhus or other forms of infection. So I think what's hard about it is it's really hard to diagnose particular infections from that artwork, but it's really the best source that we have of understanding how people responded. The sad thing and the difficult thing is to imagine if you were infected and your family was infected with plague and you were placed into a quarantine in one of these pest houses, the only source of information you would get would be from the processionals that would come down the road with the deaths, you know, during the day. And maybe if you were lucky, you could lean out the window and ask, you know, what's going on? How are things going? But there was no other form of information. If you counted that with today, the information is almost on the other side of the extreme. That is, the information is too much. I find myself overwhelmed with the information coming, and I try to be very selective in what I'm reading, and I'm still overwhelmed. And social media, we have to control for what supports that, which I always refer to as an infodemic, right? That not only is information coming and being consumed at such a rapid pace, but a lot of that information is incorrect. For example, the idea that CoV-2 is an escaped or particular biological weapon, of course, has been shown from an evolutionary perspective by Professor Edward Holmes in Sydney that to be a complete mislead and misdirect and completely false. So we have to be careful. I think social media has played and is playing a similar role, but one has to be very careful in the information that's being spread and double check it and confirm it.
That's what students are good at, for sure. You showed a picture of Napoleon there. If you could imagine Napoleon having 15 minutes with world leaders today, what do you think that conversation would sound like?
Well, that's yes. What would he say? I mean, I'd have to put myself in the mindset of Napoleon. Napoleon at that time was all about, you know, becoming the emperor of France. And that piece that I showed you was commissioned to basically do that, and it really emphasized this difference between the European exceptional response to plague. We're not going to get sick. We're better than them. I think, though, no knowing, because you know, the story behind that painting, of course, is that the French troops were also sick with plague, and he had them supposedly poisoned before he returned home to France, because to show that they returned home healthy and not sick. I think if he would be honest and admit to the leaders today, he would say, you know, we're all susceptible. Please be careful and take, you know, quarantine and flattening the curve. You know, maybe he would use some things that are very similar today.
Okay, thank you. More on, you know, you've taken such an impressive transdisciplinary approach in your presentation. This question goes back to the idea of fear. We have well-characterized viruses, but the same fear persists. In this age of heightened information exchange, we're confronted by narratives and agendas that do more harm than good. How do we fight back against this misinformation? Where do we find clarity? I know that's a huge question, but a few tips from you would be terrific.
Yeah, that's a great question, and it's a big question for an entire series for my class.
A new webinar series, yeah.
You know, yeah, new webinars. You know, the one thing is to go to sources whom you trust, and that may sound easier than it appears. But for example, the WHO has daily briefing on what's happening. They're well seeded information that are coming from, that are well poised in and clarify information. I think the first thing to always to consider is that absolutes are always dangerous, right? When an epidemic is erupting, all the stories and everything that I'm telling you about the Black Death and Plague and Justinian, I have the hindsight of 600 years or greater. And that's much easier to do from this perspective with hindsight than it is to do in the midst of an epidemic. So the question is really to pick a few sources whom data you trust. Don't expect things to not change as new data comes in. For example, the mortality rates began, you know, we saw them, they were 10%, then they were 3%, then they were 0.1%. And of course, that all depends on how you calculate those mortality rates. So I think a few trusted sources, you know, keep your faith in science. There's a lot of phenomenal scientists doing outstanding work out there, as well as social scientists thinking deeply about the implications of our behavior and how our behavior plays a role, but limit perhaps the number of sources you're seeking information from. There always will be incorrect information, and there certainly was during the Black Death. There were snakeskin oil sellers trying to sell exploding frogs at the time was a way to prevent yourself from getting plague. You'd have a frog and you'd boil it and it would explode in your house, and that was a way to keep yourself safe, which of course I don't advise anybody trying to do or use as a form of, and that happens today. You know, we know, for example, the chloroquine example that Didier Raoult in France claimed as I think the data on that is quite convincing that it does not work from the evidence that's now coming to light. So I think part of the problem is that we're expecting the cures to travel at the same speed at which information does. And science, despite the rapidity at which we're moving in the genomic epidemiology, does not move that fast. And so we're going to have to be patient, and that's hard to do for a population that is used to moving around, jet setting around the globe. I was moving, you know, with my wife to excavations, you know, quite often and frequently throughout the year. That's something we really need to think carefully about at a climate level as well.
Okay. I want to just probe that a tiny bit further. What do you do when you're in a social situation and in the conversation comes up information that you know is completely inaccurate? How do you as a scientist deal with that on a personal level?
Well, my first response is to say that that's complete, utter beep. But of course, within the context of trying to understand the nuances of the cultural differences, right? So in many cases, I have to realize and understand that I come from a completely privileged environment. I come from a privileged access to information, from a privileged knowledge base upon which to say that. So I try to do it in a way that maybe isn't as personally upsetting to a particular individual, but I think the only way to do it is to be very, very clear. You know, we have a situation, for example, of in Canada at times, people not obeying the quarantine laws, and it creates this very awkward space of telling people, you know, when you see them at your neighbors or something, that this is not really what needs to be done. No one likes to be a snitch. No one likes to be a tattletale on the own. But the problem is that people need to realize that these things matter for other people down the road, and it's an extremely selfish position to place yourself in. So one has to be firm, but I think kind, so that you're not shut out.
Okay, great. Thank you for taking that one on. So many questions are coming through here. The next one is about the end of your presentation where you commented about the need to be vigilant. Would you say the way COVID-19 has spread globally is due to a failure of our leaders to be vigilant? And can you speak to what kind of vigilance you recommend? So the first part is, would you say that the way COVID-19 has spread globally is due to a failure of our leaders to be vigilant? And the second part is, can you speak to what kind of vigilance you recommend?
Sure. I mean, both very interesting and important questions. I mean, unfortunately, throughout history, epidemics and the failure to maintain or quarantine them is really seen as a failure enough. So we know that China went through an amazing quarantine operation, unparalleled in anything that we've ever seen, except for some things maybe during influenza in certain cities, for example, in St. Louis as opposed to Philadelphia. But at the same time, the government, of course, needed essential information, or at least from what I understand from my reading, of course, and I need to be careful not to spread misinformation, but from what I understand, there's always this fear of being stigmatized, and that fear of stigmatization is so great that it'll lead responsible, smart leaders to still go with the denial game as opposed to immediately admitting it. Why? Because they know down the road it's going to be called the Chinese virus or the Spanish flu or some other forsaken disease. And so it's this delicate balance between driving fear into a population, also the fear of repercussions, which of course we see operating at a global scale today. But I think ultimately it does calm down to the leader. You are the leader of a particular country. It is your duty to get out ahead of that and say, this is a real thing. This is happening in real time. We need to do the following steps. I think for me, vigilance means really paying attention to rapid screening. So in the case of flus and the production of flu vaccines, we have screenings in place. For example, through WHO and through the CDCs in the United States, there are active groups involved in screening for the presence of circulating strains that are then guessed based on modeling as to whether they're going to become worldwide strains at the epidemic or pandemic level. And of course, these are the strains that are usually put into vaccine production. So vigilance here would be, we need to screen animal reservoirs for the potential of RNA viruses, which are probably going to be the biggest threat in terms of zoonotic transfer. And there are groups, for example, the PREDICT group out of UC Davis was defunded in 2019 by Donald Trump. Now recently, I believe, refunded by Nancy Pelosi, the Speaker of the House, to look for these types of coronaviruses in bats. And so I think vigilance really means paying attention, doing our best science in terms of reporting issues, trying to overcome the fear of stigmatization and blame that will ultimately, unfortunately, result in identifying a pandemic in your own place. And having leaders ultimately say, you know what, we need to be thinking at a global level rather than a nationalistic level, and inform people immediately that this is an issue and shut travel down.
Okay. There's a number of questions coming through. I'll do one last one for you, Hendrik, and then we'll have to start to wrap up. But as we had said before, we'll put the questions on the Global Health website, and perhaps you could take a crack at them afterwards. So this last one, thinking of the Spanish flu that took place during World War I under such a complex setting, what lessons can we learn to deal with pandemics under current socioeconomic issues? For instance, refugee crises, camps, and low resource settings.
Yes, I mean, this is, it's always the case that plagues affect disproportionately situations in countries of lower socioeconomic status, people that are in the midst of both civil strife or war, refugee status. They are always disproportionately affected. Why is that? Well, A, access to healthcare is very limited at best. Access to proper food and nutrition. We know that proper nutrition leads to a better immune system, a more primed immune system, and without that, you have heavily immunocompromised individuals, and we know people with underlying co-infections are going to have higher mortality rates. There's no question throughout cholera epidemics of the past, throughout typhus epidemics of the past, for example, in Napoleon's march to Russia and back, he lost almost 90% of his entire force by typhus because of being in war without nutrition. And of course, the populations in cities that they decimated along the way were also rapidly infected with typhus as the soldiers moved through. This is going to continue and has been a huge problem throughout pandemics in history, and will disproportionately affect those. Right now, most of the news reporting, certainly from my vantage point, has been predominantly on Western, outside of China, has been really about mostly Western European and North American countries, which of course is hugely biased. The real toll of the pandemic that I fear about is once it has and continues to hit Central, South America, as well as parts of India and Africa, what will that toll look like, and how will the afflicted be both helped and, worse, stigmatized?
Interesting. Do you have any predictions on that? You're sort of ending your question with a question, and I'm just wondering if you have any predictions on that.
Well, I think it'll hit disproportionately those populations and those health infrastructures as well. The big hope that summer and warmth and humidity might alleviate the COVID problems is certainly disrupted by equatorial, lined countries that are currently seeing repeated and high mortality rates from COVID. So I don't think it ends in a positive way. I just hope that we report on it fairly and do the best that we can at a global level to help these populations that are going to need it.
Well, on that note, I want to thank you for your compelling compelling presentation. And I want to thank people who were involved in the chat there with your compelling questions. It's really helpful to hear a connection between the past, the present, and the future. And I think the questions in the presentation were really informative in that regard. So I want to thank everybody for that. And Hendrik in particular for your presentation. It's just outstanding. And so let's just quickly wrap up. Sorry, go ahead.
No, I just want to thank you. I want to thank you for the opportunity to speak. I want to thank you for everybody that's been online and listening to me. And yeah, I'll be happy to address questions if you have it. And I haven't been able to get to it. Thank you again. So much. Stay safe, everybody.
Okay. So let's just quickly wrap up. We hope that the information provided was relevant and useful to everyone in the webinar today in expanding your understanding of pandemics. I want to thank you all for attending, and again, special thanks to Hendrik Poinar for an excellent presentation and your invaluable insights provided in the Q&A. Looking ahead, we look forward to hosting the second webinar entitled Canada's Research Response to the COVID-19 Pandemic. This will be this Friday, April 24th, from 10:45 to 11:45 Eastern Daylight Time. And this time it features Dr. Charu Kaushik and Genevieve Boillet-Larouche of the Institute of Infection and Immunity from the Canadian Institutes of Health Research, CIHR, and McMaster University. In this webinar, you'll learn about Canada's response to the COVID-19 pandemic thus far, and some of the questions you raised were leading in that direction as well. If you haven't registered for webinar 2 or for other webinars in this exciting series, please go to the link on the website, globalhealth.mcmaster.ca/2020 webinar series. So enjoy the rest of your day, everyone. We look forward to your participation in our next exciting webinar. Thank you.